So this chapter is on dysrhythmia. So we will learn about the normal heart rhythm, and we'll also learn about several abnormal cardiac rhythms. Dysrhythmias and arrhythmias are interchangeable. They're utilized the same. So whether you say dysrhythmia or arrhythmia, it's pretty much the same. In this chapter, we will also learn about how to treat the certain dysrhythmias or arrhythmias. And before we move on, we will discuss the normal conduction pathway. So the really cool thing about cardiac cells, all cardiac cells have these four properties to them. So whether the impulse is coming from the SA node or if it's just from a random cell somewhere within the atria or even the ventricles, all cardiac cells, all cells in the myocardium have all four of these properties, which is how dysrhythmias come about. So automaticity is the ability to initiate an impulse. So any cardiac cell can initiate an impulse. Excitability is the ability to be electrically stimulated. Conductivity is the ability to transmit that impulse. And contractility is the response mechanically, which is usually muscle contraction, to that impulse. So this picture depicts the normal conduction system of the heart, so the normal pathway that the electrical impulse travels. So in a normal heart rhythm, our pacemaker of the heart is the SA node. So the SA node, its intrinsic heartbeat is 60 to 100 beats per minute, which would be our normal heart rate, right? And that's because that is the pacemaker of the heart. That is what the SA node sets. So to go through the normal conduction pathway of our heart, we start in the SA node. From the SA node, our impulse travels via the internodal or interarterial pathways. This then goes to both atria. From the atria, it goes to the AV node, across the bundle of His, into the left and right bundle branches, and then down into the Purkinje fibers, where then it causes mechanical stimulation of the ventricles. Any alteration in this normal conduction pathway results in some sort of arrhythmia or dysrhythmia. Sometimes those dysrhythmias or arrhythmias can be just one external beat, can be one missed beat, sometimes we call them, and this would be considered an ectopic beat or a beat that comes outside of the normal conduction system. We need to keep in mind too that these arterial pathways are fed into the muscle tissue. So if a piece of that muscle tissue is injured because of an MI or we have some sort of infarction, we are not going to be able to deliver those electrical impulses into the myocardium. When we talk about coronary artery disease, we will talk about how dysrhythmias are one of the most common complications related to an MI. So let's take a review of the autonomic nervous system. So our autonomic nervous system is divided into two branches, our parasympathetic nervous system, or PNS, and our sympathetic nervous system, or our SNS. So we're going to do a little bit of a review on this because it really helps us understand some of the medications that either stimulate or decrease the heart rate. So when we talk about the parasympathetic nervous system, the catecholamine responsible for stimulating our PNS is acetylcholine. So if we stimulate the parasympathetic nervous system, or if we inhibit the sympathetic nervous system, we get a decreased rate of the SA node and a decreased impulse conduction through the AV node, which means that we will have a slowed heart rate. For our sympathetic nervous system, the two catecholamines responsible for that are epinephrine and norepinephrine. So when we stimulate our SNS, we get an increased rate of the SA node, or increased heart rate. We get increased impulse conduction through the AV node, but we also get increased cardiac contractility. So the heart will beat stronger, has a positive inotropic effect. So the sympathetic nervous system has two receptor sites that we need to know about: beta and adrenergic. And each beta or beta receptors have beta 1 and beta 2. And then our alphas also have alpha 1 and alpha 2. And these are the receptor sites responsible for the sympathetic nervous system. So they have receptors for epinephrine and norepinephrine, which makes sense, right? So when we stimulate beta 1, we stimulate primarily the heart. So beta 1 are receptor sites that are located on the heart that will increase contractility and increase the heart rate of the heart. Beta 2 is primarily located on the lungs, and we talk about beta 2 when we get into respiratory medications. And a good way to differentiate between beta 1 and beta 2 is we have one heart, beta 1, and we have two lungs, beta 2. So when we stimulate beta 2, we get bronchial relaxation, right? Because when we stimulate the sympathetic nervous system, it's our fight or flight, and part of that is bronchodilation to be able to get in more air. Our alpha receptors, there's alpha 1 and alpha 2. We're going to talk about alpha 1. We have alpha 1 receptors in our vascular system and in our arterioles, so in the muscular lining of our arteries. And this is responsible for vasoconstriction. So when alpha 1 is stimulated, so when norepinephrine or epinephrine sit their little bodies on the alpha 1 receptor sites, it results in vasoconstriction. So moving back into dysrhythmias. So dysrhythmias is a disorder of the impulse formation, so where the electrical signal has started or what cell has been stimulated. The conduction of the impulses, so if it doesn't follow that normal conduction pathway that we reviewed a couple slides ago, that results in a dysrhythmia. Or sometimes it can be both, where the impulse doesn't start in the SA node and it follows some wacky pathway. So that would be a cause for a dysrhythmia. So we have our normal pacemaker of the heart, which is 60 to 100 beats a minute. So when someone says, what's a normal heart rate? Why is it 60 to 100? Because that's the internal pacing system of the SA node. So let's say that our SA node decides to take a break. We luckily have two backup pacemakers or secondary pacemakers that will take over to stimulate the heart. So we have our AV node, and that intrinsic heart rate is 40 to 60 beats a minute. So not ideal, but at least we're still working it. And then we have our Purkinje fibers, and that's only 20 to 40 beats a minute. So usually this is not a very good rhythm, but again, at least our heart is still pumping. Sometimes what happens is the cells in our secondary pacemakers, like our AV node or the Purkinje fibers, they can get a little extra excited and wind up stimulating some external beats because it's more excited than what our intrinsic SA node is. So sometimes we can get little ectopic beats or escape beats from the AV node or the Purkinje fibers. Because, like I said before, really any cardiac cell has the ability to electrically, become stimulated and transmit that impulse, which then results in cardiac contractility. So it's kind of cool. So our ECG monitoring is the graphic tracing of electrical impulses that are produced by the heart. And we see these as waveforms, which really those waveforms represent ions, electrically charged ions that move across the membranes of the myocardial cells. So this is the picture of a normal ECG. So let's go through some of the different waves and what they mean. So number 1 is a little hump before the big spiky thing. So the little hump, number 1, is called the P wave. And the P wave represents atrial depolarization. And when we depolarize, we can assume that the atria is contracting. But we need to remember that an ECG is the electrical activity of the heart. It's not the mechanical activity. So just because you have a huge P wave doesn't necessarily mean that the atria is contracting way harder than if somebody has a little baby P wave. It's the electrical activity. So the P wave represents atrial depolarization. Then we have number 3, which is the big spiky thing. So number 3 is actually 3 different letters. It's called the QRS. So let me get my little pen here. So it's let's get yellow since everything else is red. So we have the Q, the R, and the S, right? The different points. So the QRS is ventricular depolarization, okay? And then we have number 5. 5 is our T wave or ventricular repolarization. So this is when the ions travel back to make the heart be able to be stimulated again for the next heartbeat. So we have the P wave, the QRS, and the T waves, 1, 3, and 5 that we reviewed. So what about atrial repolarization? So the ventricle repolarizes to get ready for the next heartbeat. How about the atria? And actually the atria does repolarize, but we don't see that graphically traced, because it's hidden within the QRS. So while the ventricle is contracting, number 3 or the QRS, the atria is repolarizing. But because there's a greater electrical activity with the ventricle depolarizing, we don't get to see that graphically traced, but it is happening. So then we have number 2, which is our PR interval. Our PR interval is the impulse from our SA node traveling through our intra-arterial pathways down to the AV node through the bundle of His, down the left and right bundle branches into the Purkinje fibers, and just before ventricular contraction. So our PR interval gives us a good idea about how long it's taking for the electrical impulse to be traveling through the heart. So a normal PR interval is 0.12 to 0.2 seconds. We review these numbers again when we go through our different rhythms, so don't fret yet. Our normal, we measure our QRS as well. A normal QRS, how long it takes for the ventricles to depolarize, is 0.08 to 0.12. So really it's anything less than 0.12 for a QRS. We'll just say less than 0.12 for a QRS wave. It's just much easier. Then let's see what else we have here. We have number 6. So number 6 is our QT interval. Many medications out there actually affect our QT interval, and this represents the entire time it takes for the ventricle to depolarize and then repolarize again. So how long does it take for the whole ventricle to do its thing? The problem is if our ventricle takes too long to repolarize, let's say it's taking a really long time, we have cardiac cells that are getting a little impatient and can jump in there and cause an ectopic beat or cause another ventricular beat. So if you took psych, if you remember, some of the psychiatric medications can cause QT prolongation if they are overdosed, especially tricyclic antidepressants. They cause QT prolongation. That just means that if they overdose on tricyclics, they're at high risk for ventricular dysrhythmias because of the prolonged QT. A normal QT, so a normal number 6, is 0.36 to 0.44 seconds. So it is a little bit longer. And number 4 is our ST segment. We're not going to worry about the measurements of that, but we do talk about this little guy with coronary artery disease and acute coronary syndrome. So we have this isoelectric line. Where's my little mouse here? There it is. So we have this isoelectric line right here. So basically, anything that is drastically different from this little line, oops, can't do it here, is off the isoelectric line. So if our ST segment was like way up here, that would be an ST segment elevation. If our ST segment was like way down here, it'd be an ST segment depression. And usually it's not a line, it's usually like a droop. So that's what we will know about for number 4. We're not going to measure that. So an EKG can really give us a whole slew of different information. Like reading a 12-lead EKG, we can get an idea on some structural changes of the heart, such as hypertrophy, ventricular hypertrophy. We can also obviously determine conduction problems, drug toxicity or drug overdose, which we just talked about, right, with our QT prolongation. And we can also see if there's any damage to the coronary arteries, because that could affect conduction, our normal conduction pathway. So really we can gather quite a bit of information just on this, just on EKG. So let's just discuss ECG lead placement. So this picture is for a 5-lead EKG, which has 2 electrodes that are placed kind of around the shoulder area, 2 on the abdomen, and then 1 about the 3rd or 4th intercostal space down, just right of the sternum. They are labeled RA, LA for right arm and left arm, and then RL and LL for right leg and left leg, except we really don't put them on patients' arms and legs just because it's inconvenient. It's difficult for them to move. It would create a lot of artifact, or it would create the EKG to look like it's not working really well. Each of the leads is also color coded, so it's universal, so it doesn't matter what facility you go to. They're all going to be, the same colors are going to mean the same things. For example, the white lead is always the right arm lead. The left arm is always the black lead. The RL for right leg is the green lead. LL is the red lead, and then the one that is in the center of the chest there is the brown lead. And there is cute little phrases to help you remember where each of the leads go. One of the phrases goes white on the right, so that would be for the right arm, and then clouds over grass. So the clouds would be on the right, and it would be the white lead. And then the green lead would be on the RL because clouds over grass, white over green. And then it's smoke over fire. So on the other side, the left side, the left arm would be black for smoke, and the left leg, or LL, would be black or red for fire. If the color of the leads are mixed up, or let's say you put the left arm lead or the black lead on the right side, that would cause your EKG to have a different appearance. Some of your waves might be inverted, so you might have an inverted T wave, which is not correct. So a couple slides ago, we discussed how, let's say the PR interval is 0.12 to 0.20 seconds. So how in the heavens do we measure that? Well, EKGs are done on the specific ECG paper, which is shown here. So just to tell you, on every piece of ECG paper, there's black lines, which I am re-highlighting, which depicts 3 seconds between each. So from this line here to this line, it's 3 seconds. And then again, from that one line to here is also 3 seconds. So this is a 6-second strip, which we usually always want. And we want to get at least a 6-second strip anytime we print something or anytime we're looking at an ECG. So each one of these has a big bolded black box here, which is, I'm trying to outline, a little bit more difficult than. So this is a big box. So this measures voltage, and then horizontal measures seconds. So each black box, so from here, let's say here to here, is 0.2 seconds. Then there's little boxes in here. So from one little box to the other little box here, those two lines, that is 0.04 seconds. So it makes perfect sense. So if one big box here is 0.2 seconds long, and there's 5 little boxes, 1, 2, 3, 4, 5, 0.04 times 5 is 0.2 seconds. So one little box is 0.04. So we would take calipers and literally measure out how long the PR interval is, how wide the QRS is, and then we would also measure the QT interval. So there's several different ways we can calculate heart rate by looking at an ECG rhythm strip. Obviously, we could listen to somebody's apical heart, or we can palpate their radial pulse for 30 seconds if it's regular and then multiply by 2. But looking at an ECG strip, we can count the number of QRS complexes in 6 seconds, since we always need a 6-second strip, and then multiply that by 10, because 6 times 10 is 60, right? And then 60 seconds would be a full minute. Yeah, we all know that. So if you look back on slide 8 and count those QRS complexes, there are 7. So we can assume that that patient's heart rate is around 70. So it's a guesstimate. It's not something that is, written in stone. But if somebody's heart rate was going fast, you could better be able to tell, how fast that heart rate is going. Again, it only works for regular rhythms. So this would not be a preferred method if somebody had an irregular heart rate like AFib. There's 2 other methods. The number of small squares between one R to R interval, blah, 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 and the number of large squares between. Those are just 2 other methods that are rarely used because it's kind of crazy. Ain't nobody want to count the number of small squares between one R to R interval and divide it by 1500. It's not something that we can do easily. But there are other methods that you can use, although the 6-second method is the most common. This slide shows some artifact. So artifact can come from numerous different things. It can come from patient movement. It can come because electrodes aren't placed correctly, meaning maybe they're just like floating on chest hair and they're actually not secure against the skin. It could be because the jelly dried up on the back of the electrode. When we have artifact, we want to make sure that we check the patient, obviously, and that we secure any of the electrodes. Sometimes we actually have to change around where those electrodes are placed. For instance, if those leg leads are too close to the diaphragm, we'll get artifact because the patient is breathing. Clearly, we don't want them to stop breathing, but we can just move those electrodes down the abdomen a little bit to decrease the artifact. So the role of the RN is to interpret the rhythm and evaluate the clinical status of the patient. So there are generally on a telemetry floor monitor techs. So their job is to interpret the rhythm and to monitor the rhythm for any changes. They cannot assess your patient based on those changes. So you still need to know what's going on and what the rhythm of your patient is. And part of that monitoring is determine if the patient is hemodynamically stable, right? We just talked about that in our hemodynamics portion, right? So we would know if they're hemodynamically stable based on their mentation, based on their skin color, their pulses, their vital signs, potentially urine output, right? So many different ways we could determine if the patient's hemodynamically stable in comparison to the type of rhythm that they're in. Determine the cause of the dysrhythmia and then treating the patient, not the monitor. So I've taken care of patients who have been severely bradycardic. Their heart rate is so low, but they're not symptomatic at the time. They're hemodynamically stable. So are we going to treat them? No, we're certainly going to monitor them, but we're not going to treat them aggressively at that point because we're treating the patient, not the monitor. Some things that dysrhythmias can cause or conduction abnormalities in general can cause. Conduction abnormalities can cause syncope or falls, especially in the elderly, dizziness, shortness of breath, palpitations, exercise intolerance, increasing fatigue and weakness, especially as the day progresses, confusion that can actually lead to heart failure. So rhythm changes are a serious problem. And of course, there's death too. So when we're looking at a rhythm strip, these are all of the things that we want to take note of. So we want to look at the P wave. So the P wave should always be upright. So it should go up and not down, right? It shouldn't be inverted. It should be up, upright. And there should be a P wave preceding or before every QRS complex. We also want to make sure that it's monomorphic, which means that it pretty much looks the same every time there's a P wave. So one's not, super large and the other one's just a little baby P wave. They should be pretty monomorphic. They should be of the same shape and size in general. Then we want to look at the atrial rate and rhythm. So if there's a P wave for every QRS complex, the rate and rhythm would be the same as our ventricular rate and rhythm would be the same as our QRS complex, right? Yepers. Then we want to look at our PR interval. So that's the time that the impulse takes to travel all the way through the atria, internodal pathways, into the AV node bundle of His, down the left and right bundle branches, and into the Purkinje fibers, and just before ventricular contraction. So that would be our PR interval, and our PR interval again is 0.12 to 0.20 seconds. Then we would want to look at our ventricular rate and rhythm. So we would do this by looking at our QRS complex. So we would count our QRS complex, and we would also measure the distance between every R to R interval. So we would want to make so that would help us determine regularity. The QRS complex needs to be less than 0.12 seconds, so we don't want that super wide. We want to look at the ST segment to make sure that it's on the isoelectric line. So we want to make sure that it's pretty flat, it's not elevated or depressed. Our QT interval, we want to make sure that it's not a prolonged duration. 0.36 to 0.44 is a normal QT interval. And then we want to look at the T wave as well. Is it upright or is it inverted? So there's many things that we look at. We look at each of the different waves, and they all have characteristics that mean they're normal. So just so we have some comparison, this is normal sinus rhythm. So if we count these, every QRS complex, there are 6 of them. So this heart rate is 60, which is within our SA node range, let's say 60 to 100 beats per minute. And this follows a normal conduction pathway. So it's regular, so they're the same distance between every R to R interval. The P waves are all upright. There's a P wave preceding every QRS complex. If we were to measure the PR interval, we would see that it's about 0.16. Is that what it looks like? That's what it looks like to me. Our QRS complex is about 0.04, maybe 0.06. So that's less than our 0.12, so that's normal. So these are some things that we consider when we're talking about normal sinus rhythm. This is what we want. So let's look at sinus bradycardia. So sinus means that the impulse is still coming from the SA node. It's just much slower. So some reasonings that some patients could have sinus bradycardia is maybe they're an athlete, right? Somebody who runs a lot or who is really aerobically trained can have a slower heart rate, and that's normal for them. So they are asymptomatic. We're not going to treat them just because of the number, correct? Stimulating the vagus nerve or decreasing the sympathetic nervous system, right? Our vagus nerve is part of our PNS, so that would make us bradycardic. Sometimes medications, hypoxia, sleep. So there's many different reasons for sinus brady. So there's still a consistent distance between every R to R interval, every QRS complex, it's still the same distance between them. There's a P wave preceding every QRS. The T wave is upright, it's regular. Our PR interval is 0.12 to 0.20. It looks like it's 0.16 here. Our QRS complex looks like it's maybe about 2 little boxes, so 0.08, so it's less than our 0.12. So let's move on with bradycardia. If I was not an athlete and experienced sinus bradycardia, some of the clinical manifestations that I would have are as follows: the hypotension, pale cool skin, weakness, angina or chest pain, dizziness, syncope, confusion, shortness of breath. So any of these manifestations would indicate a decrease in cardiac output, right? Our hypotension, our pale cool skin. So this would make us think that somebody was not hemodynamically stable. Sometimes patients even get nauseous if they're very bradycardic, especially if that vagus nerve is innervating there. Diaphoresis. So there's many different clinical manifestations, but we always need to ask ourselves, is the patient symptomatic? If the patient does present with the symptoms on the previous slide, we would treat them with several different things. So atropine is our medication of choice. So atropine is an anticholinergic agent, right? Acetylcholine or cholinergics are the ones that stimulate the parasympathetic nervous system. So an anticholinergic would be anti-parasympathetic. So it would be blocking our parasympathetic nervous system and allowing our SNS to increase the heart rate. So this is atropine. Atropine is given IV push, and we would expect somebody's heart rate to increase after atropine was given. If that doesn't work, we can do pacing. There's several different types of pacing which are presented later on, but we could transcutaneous pace somebody, so we could actually place pacer pads on somebody and pace them that way. Anytime we use a transcutaneous pacemaker or pacer pads placed on somebody's chest, we need to make sure that they are sedated because it does hurt. And then stop any offending medications. So if the reason why they are super bradycardic is because they got a crap ton of beta blockers, right? Beta is part of our sympathetic nervous system, and if we block our betas, we're blocking our sympathetic nervous system. So we would stop giving them those medications that are making them bradycardic. So let's read through this together. So a patient's cardiac rhythm is sinus bradycardia with a heart rate of 34 beats a minute. If the bradycardia is symptomatic, the nurse would expect the patient to exhibit, I'll give you a minute, so the answer is D, shortness of breath. And shortness of breath would be because we're unable to perfuse the body, right? Our heart is not pumping, it's not meeting its cardiac output needs. So sinus tachycardia is a heart rate greater than 100. So what makes it sinus, and how we know that it's sinus, is because it's regular. So it's the same space between every QRS complex, right? So from here to here would be the same as it was from here to here. So it marches out, as I call it. There's a P wave preceding every QRS. The P wave is monomorphic, it's upright. If we were to measure our PR interval, it would be 0.12 to 0.20 seconds. Our QRS is narrow, it's less than 0.12 seconds. And our rate looks like it's about 130. Some causes of sinus tachycardia vary. So exercise can cause sinus tachycardia, caffeine, any sort of stimulants, whether they be illegal drugs or over-the-counter medications, anxiety, Sympathetic nervous system stimulation, so like our fight or flight response, fever, pain, nicotine, hyperthyroidism, hypovolemia. So there are many different causes for sinus tachycardia. Again, we always want to look at the symptoms to see if patients are exhibiting clinical manifestations relating to their heart rhythm. So clearly, if I was exercising and I was sinus tachycardic, that's a good thing. So we would not need any intervention. So some of the symptoms: dizziness, dyspnea, hypotension, chest pain, especially in patients with coronary artery disease because they're unable to perfuse their coronary arteries. It's too much demand on their heart when the heart is beating too fast. Remember, increased contractility and increased heart rate lead to increased oxygen demand. And if that oxygen is unable to get to the myocardium, it's going to cause chest pain. Sometimes patients get skin flushing. We can also have diaphoresis. So there are many different types of manifestations. So let's see some of the treatments. One of the best ways to treat sinus tachycardia is treating the underlying cause. So figuring out why they are sinus tachycardic. Usually, if you were to treat sinus tachycardia with, let's say you see beta blockers there, we might be masking something that's actually causing the sinus tachycardia. For example, pain. If somebody came out of surgery and they're in the PACU and they're tachycardic, we should think that, hey, they're tachycardic due to something. Either they're hypovolemic, they might be bleeding, they're probably in pain, they might be anxious. We're not just going to load them up with a bunch of medications to decrease their heart rate. So we always want to do a thorough assessment and make sure that we're gathering all of the information we need to determine the reason, the underlying cause of that sinus tachycardia. We could do the vagal maneuver, which is having someone bear down. That would stimulate the vagus nerve and allow somebody's heart rate to decrease. And of course, we love drugs. So there's some beta blockers just in case we need them, right? So beta blockers would block our beta sites, especially our beta 1, which are located on our heart, and decrease the heart rate that way. So premature atrial contractions, or PACs, they occur when a cardiac cell within the atria stimulates a beat before the next SA node beat. So my SA node is going along, it's stimulating a normal heartbeat. Then some erroneous cell outside of the SA node stimulates a heartbeat. Because remember, all cardiac cells have the ability to become electrically charged and then transmit that impulse, which then results in mechanical activity. So that's exactly what's happening here. So let me get a pen here. Is this going to work? So this is a sinus beat, and then some sort of cell in the atria gets excited and kind of squeezes in another beat before the next sinus beat is due. So then we go along again and this SA node takes back over. We have sinus, 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 sinus. And how do I know that this just isn't sinus arrhythmia? Because that could happen too. It's because our P wave is different morphology. See, they're different than these spiky ones. They're a little flattened, so that's one of the reasons we can tell. And the other reason we can tell is because it's sinus every other where, this continuously marches out, which wouldn't happen if it was a sinus arrhythmia. So this slide just reinforces what I said. So there's some ectopic focus, so there's some cell within the atria that is becoming electrically charged, and that stimulates an electrical impulse that travels across the atria. And because that stimulus is coming from a different part of the atria other than the SA node, it creates this distorted P wave, or this P wave that doesn't look like the rest of them. Some of the causes of PACs are as follows. So PACs in general are fairly benign. They're not something that would cause us to immediately take action. Of course, any sort of ectopic beat outside of our normal conduction pathway would make us think, hey, what's going on here? But the fact of the matter is, you probably have had some PACs. I know that stress really isn't probably a part of your life right now. I'm kidding, I'm sure it is. But that can cause in itself PACs. You probably haven't felt them, which is perfectly normal. If you've drank a bunch of caffeine, or if you've had a couple cups of coffee, you may have had some PACs and may not even know it. So the frequency of PACs would really determine our treatment. The only clinical manifestations is it might be felt. You might feel your heart skip a beat, or maybe you don't. If you have frequent PACs, it could cause some dizziness. If you were having, let's say, every other beat was a PAC. For our treatment, we would monitor for more serious dysrhythmia since it's a fairly benign rhythm and it happens in a healthy heart just because we have other things going on, like lack of sleep and exhaustion and stress and what have you. So withholding sources of stimulation, so don't drink that third cup of coffee. And then for patients who are symptomatic or maybe have some underlying cardiac disease who we don't want having frequent PACs, they could be prescribed beta blockers. But in general, this is something that we would just want to monitor. It's nothing that we would, hold the horses for and take action. So this is atrial fibrillation. So AFib is probably one of the most common abnormal heart rhythms. So when we talk about the elderly population, we discuss that they have a decreased number of pacemaker cells in their SA node, which would make it more prone for other cells to take over, and that's what's happening in AFib. So if I only have about 10% of cells that are working in my SA node, there's going to be other cardiac cells that take over, and that's what's happening in AFib. So if we were to have a picture of the heart, instead of just having one cell that's getting excited and initiating a heartbeat outside of the SA node, it's several different areas within the atria that are stimulating a heartbeat. So we come up with these little F waves. So those little F waves stand for fibrillation. Nothing else, just fibrillation. And so my atria is fibrillating away because those ectopic foci within my atria are kind of going crazy. And every once in a while, it gets a beat out through my AV node, and that's when we see the QRS complex. Some things to remember about AFib is it is always irregular. It doesn't matter, it's always irregular. Sometimes if it's going too fast, it may appear to be regular, but once you slow it down and really analyze it, it will be irregular because we can't control the number of impulses that are traveling through to the AV node and which ones are actually going to get through or not, because it's a very erroneous, it's nothing that is a set beat like an impulse coming from the SA node. The ventricular rate really depends on how many impulses are being conducted through the AV node. So we might have an AFib with RVR, and that means an AFib with rapid ventricular response, which means that a lot of the impulses are getting through to the AV node and causing a very fast heart rate. Usually with AFib with RVR means a heart rate greater than 100. And sometimes the heart rate can get very fast, up to 180s, sometimes 200s. It really depends. Generally in AFib, the QRS is less than 0.12. It's an atrial problem. It's not a ventricular problem. So usually there's no problems within our ventricles. It's that our atria are becoming very stimulated. AFib can also be persistent. So patients can be in AFib for the rest of their lives. And as long as it's controlled and they're on some medications that we'll talk about, that's just going to be how it is. And they're going to be in AFib and they might be asymptomatic. Or it can be paroxysmal. So that's Paroxysmal, paroxysmal. So that means that it comes and goes. Usually when that AFib comes and goes, it's a very fast AFib, and then they'll break out of it. Here I am getting all excited about the spelling. There it is. So AFib can be paroxysmal or persistent. It's the most common dysrhythmia. We discussed that. It increases with age because we do have a decreased number in pacemaker cells the older we get. And it can also occur with other disease states. So if I were very sick, let's say with pneumonia, it might be the case that I wind up in an AFib while I'm sick. So before we get into the treatment of AFib, let's talk about some of the causes. So we saw in the previous slide that some causes can be due to disease states or underlying cardiac or pulmonary conditions. Other causes leading to AFib could be electrolyte imbalances, stress can lead to AFib, caffeine, and age, obviously we talked about that, hypoxia, which would also kind of encompass that underlying cardiac condition. So those are the causes. How about some of the symptoms or complications? So patients with AFib or a controlled AFib or a persistent controlled AFib may not have symptoms. Symptoms usually present when that heart rate is fast. So they have AFib with RVR, or if it's paroxysmal and fast. So they could have chest pain, dyspnea, diaphoresis. Sometimes patients feel very anxious, dizzy, activity intolerance, so they're unable to do activities that they once were able to do because their body can't tolerate it anymore. Our number one biggest complication of AFib is the risk for stroke. It's the risk for blood clots. Why? Because that atria is fibrillating. So it's actually not doing this big atrial systole, this big contraction that it normally does with sinus rhythm. So it's quivering. So we're more prone to blood stasis, and blood stasis leads to clots. Some of our treatment would be medications to control the ventricular rate. Some of those medications, there's a bunch of them. We can use calcium channel blockers such as diltiazem. Digoxin is another medication. Beta blockers or antidysrhythmics such as amiodarone. Electrical cardioversion. These are done quite a lot where patients that are in AFib are taken to the cath lab and they undergo an electrical cardioversion procedure to help the heart kind of get back into a normal sinus rhythm. Anticoagulation is needed for everyone that is in AFib. There are many different anticoagulants out there. It doesn't necessarily need to be warfarin, but patients could be on warfarin. There's Xarelto, Eliquis. There's a whole slew of anticoagulants that patients could be on. The dealio with warfarin is that they need to be within therapeutic range. Generally, those on warfarin need an INR of between 2 to 3. So that would be a therapeutic INR for somebody with AFib, an INR of 2 to 3 on warfarin. And we need to teach patients who are on warfarin to make sure that they maintain a consistent diet of vitamin K, not to avoid it. So if I have eaten a spinach salad every day for lunch for the past 25 years because I don't like change, and I wound up in AFib and I'm still eating that spinach salad while I'm on my anticoagulation, I would just instruct them that they still need to continue with that diet. So I wouldn't want them stopping to eat their spinach salad all the time, or, while they were on that warfarin, because it would change that level. So it's just to maintain consistency with vitamin K. We don't want any really big alteration in their that vitamin. The next two, radiofrequency ablation and the maze procedure with cryoablation, are just procedures that are done. They're invasive procedures, but where providers go in and either zap or freeze the little cells that are responsible for causing the AFib. So those are procedures that can be done in the cath lab. So atrial flutter is very similar to atrial fibrillation in the fact that there is a stimulus, an external stimulus that is coming from within the atria. The difference is, in flutter, it's generally one or two ectopic foci that are stimulating the atria to contract, and then sometimes those electrical impulses travel to the AV node, which stimulates the ventricle to contract. So atrial flutter has big F waves as opposed to atrial fibrillation, which has little F waves. So these big F waves are generally pretty consistent. So a flutter can be regular or irregular. And the atrial rate, or the big F rate, is much greater than the ventricular rate. So atrial flutter can also have RVR if the rate is greater than 100, which means rapid ventricular response. So clearly the PR interval is unmeasurable for both AFib and A-flutter, but the QRS, since it's an atrial rhythm, the QRS, which represents the ventricle, is not really affected. So our QRS will be less than 0.12 in a typical A-flutter. The other thing to look out for, so you'll know in this rhythm, if you look you can kind of count or see the big F waves, and they're labeled here in this picture. So you'll see 4 big Fs and then a QRS complex. And then if you count to the next complex, it will be 4 big Fs and 1 QRS and continuous. So this is how a flutter can be regular. Sometimes you can have 3 big Fs and then a QRS, and then you might have 1 big F and a QRS, so it can be irregular. A flutter, if it's regular, is described as a proportion, so it will be a flutter with a 4-to-1 ratio, which is this rhythm, which means there's 4 flutter beats to every 1 QRS, so it's a 4-to-1 ratio, this picture here. And on our next slide, we will see some of the causes. A flutter is rarely seen in a healthy heart. Generally, it happens to people with advanced cardiac or respiratory problems. It can also happen with hypoxia. So generally, people in A flutter are not healthy individuals. Most of the symptoms, which are similar to those of AFib, such as shortness of breath, decreased cardiac output, chest pain, dizziness, those symptoms result from a high ventricular rate if they have a flutter with RVR, in this loss of atrial kick, which is atrial systole. Because with a flutter, kind of the same as AFib, instead of the atria fibrillating or just quivering, it's fluttering, which is a little bit more of a motion, I guess, than fibrillation, but it's still not atrial systole. You lose that sense of kick. So you lose the fill of the ventricles, and it also leads to blood stasis within the atria and can lead to an increased risk of stroke, just like a flutter. So it's very similar to a flutter. Although it's not as common, atrial fibrillation is much more common than atrial flutter. So treatment of a flutter, we want to make sure these patients don't have a stroke. So one of the main treatments, just like in atrial fibrillation, would be anticoagulation. So either with warfarin, and the INR would still have to be maintained between 2 and 3 to be therapeutic, or they can be on other anticoagulants that don't require routine lab monitoring, such as Eliquis or Xarelto, and those are described in your pharmacology book. There's several of them. Pharmacological agents are very similar to AFib as well. We could use calcium channel blockers such as diltiazem, digoxin, beta blockers such as metoprolol, and antidysrhythmics such as amiodarone could also be used to treat a flutter. Electrical cardioversion. So we could try to zap, for lack of better terms, the heart back into sinus rhythm. And then the radiofrequency catheter ablation actually is more successful with a flutter than it is AFib, because with a flutter, we don't have that many ectopic foci, that many cells in the atria that are becoming electrically stimulated or electrically excited. So it's easier to zap those areas since there's only a few, whereas in atrial fibrillation, there's a lot of different areas that are causing those little F waves. So we pretty much summed up with atrial dysrhythmias for the most part. So now we're moving into some of the ventricular dysrhythmias, which means that there are cells outside of the normal conduction pathway within the ventricles that get excited and stimulate a heartbeat. So just like we had PACs, where there was an excited cell within the atria where the impulse got through and stimulated a ventricular contraction, we have PVCs, where a cell within the ventricle gets excited and stimulates a heartbeat. So these are all examples of PVCs. There are several different ways of describing PVCs. They can be multifocal, which means they look different. So if you look at the top there are multifocal PVCs. So one of them is really wide and distorted and the other one not so much. We can also have monomorphic PVCs, which means that they all look the same. So if you look at the second one down, let me get my little pen here. So these would be monomorphic because they all look the same. In addition, anytime we have anytime we have more than 3 PVCs in a row, it's considered a run of VTAC. So you'll see that there are 2 PVCs with the second one down, we are here, is a couplet, so it's just 2 PVCs. And then we have a run of VTAC because there's 4 PVCs in a row, which would be a run of VTAC. So we would describe that as, oh, the patient in room 6 had a 4-beat run of VTAC earlier today. Going back down the list, we're on the third one down here. So ventricular bigeminy, which means every other beat is a PVC. And then there's a ventricular trigeminy, which means that every third beat is a PVC. So there are many different ways to describe PVCs. PVCs, again, are just when an ectopic foci within the ventricle, so some cell outside of the normal conduction pathway, gets electrically stimulated and creates a beat. PVCs are always wide. The QRS on a PVC will always be greater than 0.12. Anytime we have a ventricular rhythm or a beat that is an ectopic beat within the ventricle that is stimulating a heartbeat, it is going to be widened, such as what we see with the PVCs. PVCs can be considered a tad bit more serious than PACs. PVCs are stimulated with the same, or happen with the same sort of reasons, the same kinds of causes as PACs. For example, stimulants such as caffeine Electrolyte imbalances, especially potassium. If somebody is having a lot of PVCs, we would check their potassium levels along with their magnesium, because potassium and magnesium are kind of BFFs. Usually if one's low, the other one is too. So we want to check those together. Hypoxia can cause PVCs, and absolutely in heart disease as well, PVCs are prevalent. So it's not harmful. Sometimes if you drink a lot of coffee, like I do, I'll be like, whoo, and I feel a little skipped beat. That's probably a PVC. Is that harmful? Not at all. But for a diseased heart or somebody that's having a lot of PVCs, it creates a decrease in cardiac output. Because we don't have a lot of preload, that ventricle is contracting prior to it being filled, we don't have much cardiac output with a PVC. So if we have a lot of PVCs, our cardiac output is severely declined, such as in that patient that had ventricular bigeminy, whereas every other beat was a PVC. They would probably have a low blood pressure. They might be a little dizzy. They might have decreased pulses. They may have symptoms that show a decrease in cardiac output. Sorry, I got a little confused with the pause and record button. So with PVCs, we have an apical radial pulse deficit, which means if we were to listen to the heartbeat, we would hear the ventricular bigeminy. We would hear every beat, but if we were to palpate the radial artery and listen, it would skip every other beat if we were in a ventricular bigeminy. We really don't perfuse well, especially to our periphery, with PVCs. Another cool thing is if you look at somebody who has an oxygen saturation probe on, and on the monitor, the waveform looks like this for somebody with their O2 sat, right? And then this is their EKG. They have a QRS here. Wow, this is not QRS here because that's their ventricular rate. If I had a PVC right here, you would see that I wouldn't be perfused. My O2 sat would look like this. And then I would perfuse again with my normal heartbeat. So you can actually see it on the pleth of a pulse oximetry. It would correlate. You would have no perfusion. You would not see this big hump, which is perfusion, right? On the pulse oximetry, if somebody was having a PVC, I don't know. I guess I'm a little odd, but it's kind of cool just to see. So our treatment for PVCs, correct the cause or stop drinking so much darn coffee, right? Or learn better stress management techniques. So whatever the cause may be, we would want to treat the underlying cause. For patients who have PVCs, a lot of them, and are symptomatic or do have a decline in their cardiac output, we can give them antidysrhythmics, and there's several out there. There's amiodarone. Amiodarone is an antidysrhythmic that is fabulous because you can give it IV. It's an IV drip form. It's never IV push. It's just an IV drip. And it's also available PO. There's also other medications such as Multac, which is a common antidysrhythmic. There's Sotalol, which is actually a beta blocker, but that's used as well. So many antidysrhythmics or medications that have antidysrhythmic properties that can be given to treat patients who are symptomatic with PVCs. So supraventricular tachycardia is a type of rhythm that's can be considered an umbrella term. So SVT is a heart rate, a very fast heart rate, generally so fast that we can't see any P waves, or we can't differentiate if there's little F waves or big F waves or P waves, because it's going so fast that those P waves wind up getting hidden in the preceding T wave. So supraventricular would mean electrical impulse is coming from above the ventricles, right? Supraventricular. Well, what kind of impulses can come from above the ventricles? Well, it can be an impulse from the SA node, which would mean that the supraventricular tachycardia would be a sinus tach, or It could be an AFib or an aflutter. So supraventricular tachycardia is an umbrella term because we really don't know the underlying rhythm because it's going too darn fast. We need those P waves to evaluate whether it's sinus, fib, flutter, but we can't because those P waves or F or little f waves are hidden in the preceding T wave. So there's nothing for us to measure. We can't measure the PR interval to determine those. The QRS is narrow for SVT. So the QRS is normal. It's less than 0.12. So it's a narrow complex. On the next slide, this is a persistent SVT, meaning that it's going continuously. On the next slide, we will see a paroxysmal or an SVT that comes and goes. So this is the slide of paroxysmal supraventricular tachycardia or PSVT. So we can assume that the couple beats before those really fast beats are normal, or maybe it's an underlying AFib. I don't know because we can't see it. But there's this burst of really fast heartbeats. And then the patient breaks out of them as shown further along in the strip. So this would be PSVT. So some of the causes for our SVT: overexertion, stress, imagine that, any sort of stimulant, whether it be caffeine, tobacco, any illegal substance use, illegal drugs, coronary artery disease, hyperthyroid, anything that would overstimulate the heart. Some of the clinical manifestations directly relate to how healthy the person is and how fast the heart rate is going. Generally, a heart rate greater than 150 or even greater than 180 is SVT. I have personally seen patients in like the 240s, which is crazy, and they're not feeling so well. Usually they're hypotensive, they're short of breath, they may have chest pain. Many times they're a little confused or vague with what's going on just because of that decreased cardiac output. They may be dizzy. Sometimes they're very anxious or nervous. And they could feel palpitations as well. So there's a lot of clinical manifestations. This is a rhythm where we want to get patients out of SVT because it can really lead to a decline in cardiac output and cause problems relating to that. So what do we do for this? The first thing we do when somebody has SVT or a PSVT and they haven't come out of it yet is vagal stimulation. So we would ask that patient to bear down, and surprisingly enough, it seems very simple, but it works a lot of the time just because bearing down stimulates that vagus nerve to initiate parasympathetic nervous system. If vagal stimulation doesn't work, there is medication we can give called adenosine. Adenosine is a special medication that will actually stop the heart, holy shnikes, and it will allow time for the SA node to take back over as the pacemaker of the heart. So some things we need to know about adenosine is adenosine is a very short half-life, so we have to give it very fast IV push. Sometimes 2 nurses will give adenosine to make sure that it's given fast enough. So one nurse will flush the medication and the other one will be ready one nurse will give the medication and the other nurse will be ready to flush that medication. That way there's no delay. Because it stops the heart, there is potential for that heart not to resume activity at all. So anytime we give adenosine, we should have the code cart nearby or in the room in case that doesn't happen. It's not common that happens, but again, there is the potential. And we do want patients to know that they feel awful when we push the adenosine. I've had patients tell me that they felt really sick, like really nauseous. Some patients feel like this overwhelming, like chest pain. They say that it doesn't hurt, it's just this really uncomfortable feeling in the chest. And you want to tell them, well, that's because you died for a few seconds, but we don't tell them that. But that really is what happens, right? We stop their heart, and it's a very unpleasant feeling. In addition, because we have to give it so fast, we always want to give it in the most proximal IV site. So if we had an IV in the hand and an IV in the AC, we would want to give that medication, the adenosine, through the AC because it's closer to the heart. So we always want to give it in the most proximal IV to ensure that that medication gets to the patient. We also flush. It doesn't matter if it's a central or a peripheral line. We always flush that medication fast and with 20 mLs of normal saline. You know, usually we just flush a peripheral IV with like 5 mLs. But with adenosine, we want to push that medication in fast, so we chase it with 20 mLs of normal saline when we give it. Some other medications, we could give beta blockers, right? Because that helps block our sympathetic nervous system, our beta-1 receptors. Calcium channel blockers and amiodarone are also given. And then we have a cardioversion. So cardioversion can be done to help get the heart back into normal rhythm. It kind of allows the SA node or the pacemaker of the heart to take back over. So ventricular tachycardia, we've already heard this term. This is when there's more than 3 PVCs in a row. It's considered a run of VTach. Or we can have sustained VTach, whereas it's, a bunch of PVCs and it's not stopping. So we can either have persistent or it's either sustained or unsustained. So the ventricular rate can be anywhere from 140 to 250 beats a minute. There's no visible P waves, and the QRS complex is wide. Remember, anytime we have an ectopic foci coming from somewhere in the ventricles, it causes this wide QRS complex, which is what we see in ventricular tachycardia. Some of the causes of VTach are underlying heart disease, electrolyte imbalances, especially potassium and magnesium, some central nervous system disorders, and sometimes patients go into VTach and we really aren't sure why. It's something to do with an irritable heart that, needs some sort of cardiac workup. So it's when some sort of ectopic foci take over as the pacemaker of the heart. So whatever cell is really ticked off in the ventricle, that is going so fast that it's really taking over as the pacemaker of the heart. There's monomorphic, polymorphic, sustained, and non-sustained VTach. So monomorphic looks like the slide we just saw, whereas all the QRS complexes are the same. There's also a polymorphic VTach where the complexes do not look the same. VTach is considered life-threatening. Somebody could either have a pulse or not have a pulse with VTach. So there's a pulseless VTach and a VTach with a pulse. Because of the severe decline in cardiac output, VTach is considered a lethal dysrhythmia. It's very life-threatening. And if VTach goes on for too long, it could turn into a VFib or ventricular fibrillation. And VFib is you do not have a pulse. There is no liveliness with VFib. You do not have a pulse with that. So this would be an example of polymorphic VTach, which is also called torsades de pointe. I'm probably saying that wrong. I think it's French for something, and somebody who speaks French would probably make it sound much better than I would. But usually torsades, as it's often called, is due to a magnesium deficiency. So polymorphic VTach or torsades would really be due to a magnesium deficiency. And this is what it would look like. This is polymorphic VTach. So we talked about the causes of VTach. They're listed there again. We can either have stable or unstable, either if the patient has a pulse or they do not have a pulse. And sustained VT causes a severe decline in cardiac output and can also lead to a bunch of other problems. Because this rhythm is so lethal, we do need to rapidly determine and treat the underlying cause for the VTAC. So VT with a pulse or a stable, we call it stable VTAC because they have a pulse, that's treated with either anti-dysrhythmics or a cardioversion. So even if somebody in VTAC could be alert and talking to you. I've had patients that have been in VTAC and you run in the room because you're like, oh shoot, I don't know if they have a pulse or they don't have a pulse. And you walk in, they're like, oh, hello there. They're eating their dinner. So they may be asymptomatic to begin with, but that's not going to last. They will become very symptomatic pretty quickly because it's not a rhythm that can be sustained for a long period of time. So if they have a pulse, they could either be alert and talking to you, or they may be symptomatic, such as a decreased level of consciousness, chest pain, shortness of breath. They may be pale, hypotensive, nauseous. And if they are alert and talking to you and are asymptomatic at that time, again, they will show symptoms if we do not treat that VT. If they are pulseless, we would treat that with CPR and rapid defibrillation. Ventricular fibrillation, or fibrillation of the ventricles, is where there's a very chaotic rhythm going on in the ventricles. So VFib does not have a pulse. This is a arrhythmia where basically you're dead. There are no QRS complexes, there are no P waves, everything is just a fibrillating motion of the ventricles that's not really creating any cardiac output, therefore no pulse. Some of the causes, prolonged ventricular tachycardia will eventually lead to VFib, severe electrolyte disturbances, advanced disease states, and again, sometimes patients go into VFib for unknown causes, and we talk more about this when we get into sudden cardiac death. VFib is a code situation because patients are apneic and they have no pulse. So this will be treated first immediately with CPR. It would be treated with chest compressions. Sorry, I can't talk, I guess, and ACLS. So we would do chest compressions and then early defibrillation. So as soon as somebody was able to get a defibrillator at the bedside, we would interrupt CPR chest compressions to defibrillate the patient. We would do 2 full rounds of CPR with defibrillation, and then we could talk about drug therapy such as epinephrine. So CPR and early defibrillation for our VFib patients. So just a question to break things up. So a patient in the CCU develops VFib. The first action the nurse should take is to, I'll give you a minute. The correct answer you should have chosen was B, initiate CPR. That is a first action we need to take. And then we would do early defibrillation. So we would interrupt chest compressions to defibrillate as soon as possible. But the first thing we're going to do is CPR, and then somebody else should be going and getting the defibrillator. So asystole happens when there is no rhythm at all. So it's basically somebody is flatlined. There's no heart rate, there's no electrical activity, there's no ventricular contraction, the patient is unresponsive, pulseless, and absent, or apneic. The reason why we assess this in more than one lead is because sometimes this can be present if a lead gets disconnected. It will look like somebody's flatlined or they're asystolic. So we'd want to make sure that there is an electrical activity that's happening in another lead and that's able to sense some sort of electrical activity. Asystole is not a good prognosis. It's a very ominous sign. It usually happens with a prolonged code situation or, after somebody has been in VFib, they will progress to asystole. So then it's very difficult to get patients back once they're asystolic. So it's usually a result of advanced cardiac disease, severe conduction disturbances, or end-stage heart failure, which is the HF. So we treat this with immediate CPR, so chest compressions, and then emergency medications. We do not defibrillate for asystole. Defibrillation takes that electrical activity and kind of resets it. In asystole, we can't defibrillate because there's no underlying electrical activity to begin with. So with the prolonged code, we could use medications such as epinephrine, and then most likely these patients would be intubated because they're apneic. And again, unfortunately, it's a very poor prognosis at this point. So PEA, or pulseless electrical activity, is when somebody has a rhythm, there is electrical activity that is happening within the heart, but that electrical activity is not conducting to the myocardium. So it actually looks like a normal rhythm on the monitor, but the patient has no pulse. So it's pulseless electrical activity. There are several different reasons why this could happen to somebody. You don't need to memorize these. It's just a display. If you ever hear of the H's and T's, it's a mnemonic that really helps us determine why somebody would be in PEA. And if we could quickly come up with the reason and fix that, patients could have a good prognosis. So treatment for this would be usual CPR followed by intubation and IV epinephrine. We would not defibrillate in this case as well because it's not really a conduction problem. It's not because there's an ectopic foci that is creating some arrhythmia. It's because that electrical activity is unable to conduct to the myocardium. So defibrillation would not be used in this situation. We really want to treat the underlying cause, which is looking at those H's and T's, and then CPR and epinephrine.